Good evening, everyone. My name is Philip, and this is Fatra Medical Equipment Services, Edo State, Nigeria. So, we welcome you all to today's training titled The Effective Bubble Cpap Administration. We thank every one of you for your time, and we really appreciate your effort to join us on this training, on this journey this evening. So, today we'll be having a couple of speakers. The person of Dr. Ikechukwu Okonkwo. He is a consultant neonatology, and we also have Dr. Ida as well. She's also She's also a pediatrician. She's also here with us. So they are going to giving us a full knowledge on how to properly and effectively administer bubble CPAP to newborn preteens. So, but before we go into the training totally, so we're talking about a few things here. So, Fatra Medical Equipment Services is always available to provide your needs, every technology and support that you need to provide a proper and appropriate care and support to your newborn patient. So, at the end of this training, every participant stands the chance of 50,000 naira coupon, which can be used to purchase this equipment in our facility. So, like I said, every participant stands a chance of getting 50,000 naira worth of coupons, and this coupon can only be used within the minimum period of 2 months to purchase this device in our company. As I handed over to the first speaker of the day, the person of Dr. Okonkwo Ikechukwu. Dr. Okonkwo, sir, you are welcome to the floor, sir.
All right, sorry, I think it's been an uphill task. So thank you everyone for being on the platform. Let me quickly run through these slides. My name is Dr. Okonkwo Ikechukwu. I'm going to be talking on effective bubble CPAP administration. I hope my audio is good now. Is my audio very good? All right.
Yes, the audio is very clear.
Yes. All right. Yeah, thank you. Very clear. Okay. I have no financial obligations to declare. Let's take a look at this case review. If you have a 750 gram baby at 27 weeks with signs of distress, what would you do? Normally, I remember a lot of people will give surfactants, and then some people will give antibiotics, even when you have all the features. Muting me. Hello. All right. What would you do? The options are plenty, but we need to be sure. What should you do? These are questions, possibilities. What would you do? What should you do? What can you do? We'll answer this question at the end of the presentation. All right. Can CPAP be improvised? This is a recurrent question. The answer is not something I think everybody doesn't know, but we need to think about it. Maybe after this lecture, let's answer it. Have you heard of CPAP using air? It might sound strange, but what we keep saying is that CPAP is not oxygen administration. CPAP is not a form of oxygen administration, right? All right. Now, CPAP has a very strong history, And we know that it dates back to 1971 when Gregory and his co-workers published a finding. And that finding was a landmark finding that changed the face of newborn respiratory support and respiratory support in every way. Now, Some people named it a Gregory box, and because of the increase in pneumothoraces, some people called it a pneumothorax generator. But what is key is that since 1971 till date, this device have gone a very long way, all right? And it has moved from low cost or high cost to low cost, very low cost, and today we're going to be talking about an ultra low cost devices. But the major thing is bridging the access gap. We need these people to have these devices. The big question there is, what generation of Cpap device are you currently using? You are the only person that can answer this question, right? So we now move on to what is Cpap. You know, we talk about Cpap. So, but what is Cpap? If you look at the slide, you'll see that by 1974, Cpap was still a referral device. You can see a baby in the slide. Can you locate the baby? If you can locate the baby, you're a genius. It means that a big hall will take like 1 or 2 devices. But today we are talking of a very composite device that you can carry with one hand and put it in your room, as it were. The real definition is that Cpap is the application of positive pressure. Now, look at the keywords. Positive pressure application, not oxygen administration. Positive pressure application to the airway of a spontaneously breathing infant. And that happens throughout the respiratory cycle. I need you to see the keywords. Positive pressure application, spontaneously breathing infant, throughout the respiratory cycle. It's important to know that there are multiple ways of providing Cpap. And that Cpap is a mode of respiratory support. It is a parameter that is PEP, and it's also a device for support. So you can see the information, a mode, a parameter, and a device. But it's also important for us to know that cost is becoming the defining factor of the device. Cost. And because of this, a lot of devices are coming to sub-Saharan Africa. A lot of them of low quality. But the real cost of Cpap is not actually the device. It's not just the device, but the maintenance cost and also the electricity cost. Not also talking about the cost of consumables. These are things to have in mind before you purchase a device, thinking that you are just buying a device outright. Some of them are very high oxygen consumers. Now, that implication brings us to the fact that Cpap in itself have come a very long way. And if it has come a very long way, we expect that there are some things that we should know clearly. But be it to say that, enough to say that this is the missing link to mechanical ventilation. If you cannot do basic Cpap, it means that in your practice, you're just doing supplemental oxygen. Good to hear that this Cpap is the first treatment in most neonatal intensive care units, not in sub-Saharan Africa. In most developed places, Cpap is the first treatment of choice. Very simple, inexpensive, but very effective. And the key reason why it comes to mind is because research has shown that it reduces the need for ventilation and intubation for very small babies. And it's also the preferred mode of respiratory support. What are the benefits? Reduce your need for surfactant use. Reduce the proportion of babies that need intubation and mechanical ventilation. Reduce referral. Why would you refer a baby when you have the treatment? Reduce mortality and also BPD. Some people say, do we have BPD in Africa? I say, how many 26, 25 weekers have you seen that survive? It lowers the cost of care. It's easy to operate. And today, because of the refining that has been done, it has very little side effect. Let's see how Cpap works. Is it just magical? Is it just magical? Yes, Cpap is magical. But how does it work? 4 things Cpap would do for you. Prevent the collapse of alveoli, the ones with marginal stability. Stabilize the chest wall. Split open the upper airway. And then stretch the lung, pleura, and the upper airway. Now, look at these 4 things because they are all interconnected. By preventing collapse of alveoli with marginal stability and stabilizing the chest wall, it conserves endogenous surfactant. The idea is that if a lung is not collapsed, actually, the surfactant is saved. So the timing of resumption of Cpap service will determine how much surfactant, endogenous surfactant, you save. It's also important to know that the recruitment of more alveoli will maintain the lung's functional residual capacity and increase the alveolar surface available for gaseous exchange. This is how it reduces the partial pressure of carbon dioxide and improves pH by washing out more oxygen. The interesting thing about this is that by washing out carbon dioxide, it reduces the pulmonary vascular resistance. This makes it easy for a child to transit from intra to extrauterine life. Right. So, what are the components? It's important we know the components because this will help us differentiate what is Cpap and what is not Cpap. And as a friend casually says, what is Cpipe and what is Cpap? Cpap will always have a source of gas, and that source has to be continuous. The supply of oxygen and air. Supply of oxygen and air continuously that is blended, warmed, and humidified. Just keep it in your parking lot. Does your Cpap supply continuously oxygen and air? Is it blended? Is it warm? Is it humidified? Now, you have a pressure generator, which is the underwater pressure generator for the bubble Cpap. And you have continuous flow of gases through circuits. And then you have interface. And this interface is either by nasal prongs or mass. Let's take the components one by each. For you to have effective Cpap, your blender is the first step. A blender or a mixer. It just mixes oxygen and air together. Cpap is not a means of oxygen administration. A Cpap without an air oxygen blender is only a supplemental oxygen administration device. It's also important to know that oxygen is a drug, and the fraction of inspired oxygen is the way to measure oxygen administration. So the first parameter on Cpap is FiO2. And the second parameter is PEP. So there must be a way to measure oxygen, the amount that you're given per time. Remember that the fear of retinopathy of prematurity is the beginning of wisdom. Please don't give a child 100% oxygen and let the child now be blind. That is not care. That is recklessness. It's also important for us to know that Cpap administration, the FiO2 is between 21 to 50%, after which it's no longer Cpap that you're giving. Given FiO2 above 60% is Cpap failure already. Just digest it. Now, let's look at the issue of blenders. What does a blender look like? We have two pictures there. A high-cost blender, an ultra-low-cost blender. While the other one needs oxygen cylinders or piped oxygen and compressed air and electricity and complex accessories, one only needs oxygen by any means and ambient air. There's no electricity need, there's no accessories, just a Venturi process. Now, humidity is essential, and essential to prevent desiccation and drying of the airway. It's important for us to know that when air is moving, it needs to move through a jet of humidity for it to be able to actually be useful to the baby. This humidity can be warm or not warm. So that's how you talk about active and passive, right? It's also important for us to know that heated or active humidification is more indicated in smaller babies, all right? So here we are looking at circuits. We need to use corrugated tubes, not plain tubes. And somebody will say, why? Because it's useful for trapping condensed humidity without luminal blockage. And you remember about the dewing of the tube, the misting, the raining, and the flooding. And this can be very dangerous to the baby. It also prevents the risk of kinking or bending of the tubes. And if those tubes are color-coded, they are preferably safer. Devices with plain tubes are unsafe. Cpap administration. Now, and some of us will remember the story of Purcell's law and the definition of the movement of a fluid through a particular tube and the pressure gradients and the viscosity. Talk about how they relate. The tube size, caliber, and length matters. What I need to tell you about this law is that the smaller the tube, the more resistance to flow you have. That resistance adds to the pressure. So there's a recommended tube diameter for newborn, infant, child, adolescents, and adult. If you have high pressure tubes, you actually have tubes that are not just carrying air through, but they are contributing to pressure. Right. The saying goes, not everything that bubbles is Cpap. You need to know the orientation of the bubbler and the air. Now, what is it about this orientation? It's from a study. If it's at 90 degrees, if it's a straight tube, if it's at 130 degrees, the frequency and the vibration that follows is not the same. So you need to know what kind of device you have, the orientation of the tube, and the exit position of the air. It's also important for us to know the interface, the type of interface you have in relationship to where you have flow, where the air is coming. The shaded areas are the areas that show you where you have mixing. Take a look at the third arrangement. The bubbler is on the inspiratory limb. The second arrangement, the bubbler is at the inspiratory limb. The patient is having to rebreathe. Instead of just rebreathing the prongs, the patient is rebreathing both the air he has breathed out and the air he is breathing in. That means that the ability to actually administer Cpap is poor. The other tubes on the right side cannot be used to administer Cpap. They are high flow tubes. They are ram cannulas. They are not meant for bubble Cpap because the interface between where the air enters and the mixing is so much. You cannot administer Cpap effectively with them. Right. This is the interface you need, where there is a clear marking where air, fresh oxygen comes in and where it goes out, and it fits snugly. This is a very interesting system that you can use anywhere. You can see that the eyes of the baby is visible. You can see that it is snugly placed, not plastering and holding the tubes together. By the time the mother sees the baby, it will look like the baby has had a head injury. Now, correct prongs, correct positioning, a mustache that holds and secures the system is also important. A shin strap, a neck roll, correct developmental procedures where Cpap does not block your ability to render service is also important. A head support, a sniffing position, oxygen bubbling continuously. These are key things for you to know that your Cpap is well optimized. Now, what's wrong with this setup? I need feedback on this. What is wrong with this setup? I don't know if somebody can go to the chat box and indicate an answer. What is wrong with this setup? This looks good, but there's something wrong with this setup. Just go to the chat box and indicate what you think is wrong with this setup. Quickly get to the chat box, indicate what you think is wrong with this setup, and I will give you the answer. This is a general setup for a bubble Cpap. But what's wrong with this? I'm waiting for your feedback. Well, take a look at it. If I don't get a feedback, I'll give you the answer, but I need a feedback. What's wrong with this setup? Can somebody just type in, there is no blending system? Can you see it? There is no blending system. This is not a safe device. Have you seen this device? Have you come across this device? Right. What are the indications for Cpap? First one is apnea. Baby is not breathing. Second one is tachypnea, dyspnea. Cyanosis. Silverman-Anderson scoring equal or greater than 4. Modified down score 4 to 7. Acon score 5 to 8. Any of this scoring system can be used. Somebody call it CDAT. C for diagnosis, cyanosis, D for dyspnea, A for apnea, T for tachypnea. If you have any of these, it means that something is, this child needs Cpap. If you have any of these, it means that the child needs Cpap, right? These are the indicators for Cpap, right? So, as it were, Okay. What are the other indications? This is academic. So you can look at that and see if that fits you. What are the contraindications? Respiratory failure that is progressing. If there's increasing carbon dioxide, decreasing pH, and progressive hypoxemia, it means that you are doing ABG. If there are congenital anomalies, diaphragmatic hernia, tracheoesophageal fistula, coronary atresia, you cannot do nasal Cpap. Also, cleft palate, not cleft lip, and Pierre-Robin sequence. When you have cardiovascular instability, poor respiratory drive, or you have no respiratory drive, it's important for you to know that every 7 days, you need to change the circuits and the humidification center, humidification chamber. You need to remeasure prongs and remeasure caps, discard caps that are bad or soiled, and then record equipment changes, right? Your monitoring of Cpap is basically pulse oximetry, or if you have a multi-parameter monitor. But if you have all the other components of continuous EEG and the like, you're home and dry. Please always record the information. There has to be a prescription of Cpap. What pressure do you want? And what FiO2 do you want? It's okay. It's also important for us to know that I will give out this prescription that if you want to prescribe Cpap, babies less than 500 or between 500 and 1,000, baby, they need 5. The safe pressure for Cpap is between 5 and 8 centimeters of water. Remember that the length of the tube underwater is the pressure. Between 5 and 1,000 grams, the child needs about 5 centimeters of water. Between 1,000 and 2,000 grams, child needs 6 centimeters of water. Between 2,000 and 3,000, child needs 7 centimeters of water. And between 3,000 and 4,000, child needs 8 centimeters of water. Right. Remember that your FiO2 should never exceed 50. There are 2 different schools of thought. Do we give low FiO2 and step it up? Do we give high FiO2 and step it down? I belong to the group that say give low FiO2 and step it up, because you will now know when you need to add surfactant and when Cpap has failed. Right. Always talk to the parents concerning the care of their child on Cpap. Don't assume they know. You may be shocked to find out that they don't actually know. How do you win the babies when they are doing well on Cpap? It depends on the resources available to you. Do you have an algorithm? Do you have a protocol? You may need that. Your saturation should guide you. It should always be 92 to 96. Please note that saturation of 100 is dangerous. It should be lower. So your FiO2 lowers as your SpO2 gets better. Your SpO2 relates directly to your FiO2. Your respiratory distress relates directly with your pressure. I say that again. Your SpO2 relates directly to your FiO2. Your pressure relates directly to your distress. All right? So it's also important to know when Cpap has failed. It's a very common thing that happens. A lot of times Cpap fails, and it's very high. Failure rate is high. You need to anticipate it, and we also need to know that, oh, this is failing. So what do you do when your FiO2 is going above 30 to 40? What do? You give surfactant. When your FiO2 levels are above 50, your Cpap has failed. You may have to repeat surfactant just to buy time. Cpap failure is failure of a child on Cpap that needs intubation within 72 hours of birth. And the rates are high, it's almost above 43%. So Cpap alone is not all you need. You need to add other things to it. You need to know that when your Silverman-Anderson score is above 7, it's already failure on Cpap. Modified down score or your Acon score above 8. Right. So when you see these things, you will know that your Cpap is failing. You need to do something more. Right. It's also important to know how to manage Cpap failure. Management of Cpap failure begins early. It begins with antenatal steroids. It begins with doing sustained lung inflations. It also continues with assisted delivery room resuscitation. Surfactant, whether you're using Insure Mist, delivery room Cpap, using your TPs, bubble Cpap. Now, when we say this, I need you to know that bubble is the best. So we're talking of you using bubble Cpap. Caffeine citrate administration, and check the baseline characteristics of your babies. Let's do a little comparison. What kind of Cpap do you have access to? A little color coded. Fisher and Paykel is the standard anywhere. Have you seen another type of Cpap? They are medical. Are you using Improvise? Looking at them, it will show you their classification, oxygen source, power, blending system. If you're not blending, you're not using Cpap. Humidity, warmth, tubings, interface. This will guide you to know if you're not using corrugated tubes, it is unsafe. If you're not using corrugated tubes, it's unsafe. Bubble is better. That's what I would say. How? Based on resources by Pillow and his co-workers. They found out that bubble Cpap enhances ventilation. At the same rate, bubble Cpap improved oxygenation compared to other type of Cpap. It's also important to know that bubble Cpap actually reduces the days on Cpap, and bubble Cpap reduces the percentage of Cpap failure for babies that are ventilated. These are already proven facts. Babies need respiratory support, and respiratory support needs babies. And there's a guideline that you need to use Cpap early. If you use Cpap early, you're going to reduce the incidence of BPD and death. It's so important to know that if a child needs other forms of Cpap or ventilator, you need to give surfactant. But for babies that are less than 1,500 grams, you should be allowed to stabilize on Cpap. But if these babies are needing FiO2 more than 60%, it should be intubated. For babies less than 26 weeks, they should receive prophylactic surfactant before Cpap. It means that surfactant should be available at birth and the child gets it. This is a demo to avoid, in case you don't have a blending system, please use a concentrator. If you don't have a blending system, please don't use 100% oxygen. Use a concentrator. Let's take a look at this. If you are doing only oxygen, only 25% of your babies will do well. That means that only 1 in 4 babies will do well. If you're using that for babies that need, babies that have respiratory distress, if you're using Cpap, 70% of your babies will do well with respiratory distress. If you add surfactant to CPAP, 85% of your babies will do well with respiratory distress. And if you have mechanical ventilation, 95% will do well on CPAP. If you have advanced care, 98% of your babies will do well on CPAP. So the answer to that question we started with is that this child does not need surfactant. This child needs CPAP, even though the child. Food for thought. Closing, preterm care without CPAP strategy is actually masterly inactivity. Not using CPAP, I can tell you, you're actually not doing anything for these babies. Babies need CPAP. And I always say this, that when the information changes, I alter my conclusions. What do you do, sir? And in conclusion, it's important to know that CPAP is important for respiratory and non-respiratory issues. CPAP is now a public health intervention. CPAP reduces neonatal mortality and morbidity. It's important to let our preterms live. And also, need to be more proactive. Thank you for your audience. And if there's any question, we will actually take care of it. Thank you very much.
Thank you, sir.
Thank you very much, Dr. Okonkwo. So before we go into the question and answer, we would like to welcome the second speaker, Dr. Hilda, to come and give her own speech. Dr. Hilda, please, you're welcome on stage.
Hi, good evening all. It's such an honor to be here in front of you. I am talking with you from the very cool Kenya. We are at 19 degrees Celsius today. I think Nigeria is about maybe 25 to 28 this evening. I will briefly take you through Vayue and what we are about and how we came about and our aim in neonatal care. Just a moment. Philip, can you hear me? Philip. All right, thank you. So as Philip introduced me earlier, I am Dr. Hilda Gikunda. I am a public health specialist. I am not a pediatrician, though I do a lot of pediatric work. So Vayue Global Health has been in the global health space for the last 30 years. Our founder is Professor Thomas Burke. He's the current director, the Global Health Innovation Lab at the Massachusetts General Hospital. He's both a professor of emergency medicine as well as global health and population at Harvard. And he's highly decorated. So part of the work that has been taken up by Vayue before the Vayue Bubble Cpap and the oxygen blender, one of the key ones is the uterine balloon tamponade kit. And this is part of the program in maternal and child health to manage PPH. And really, this is very exciting. This device is currently under manufacture by Another key contribution, Professor Bach has the setup of the ketamine use where there's no there's no anesthetist. So, and this protocol has now been taken up by the World Health Organization. All right, so where are we now? Vayue Global Health has come up with the world's first high quality neonatal system that does not require electricity, compressed air, or manual power. It comes with a oxygen blender manual, which makes sure we only give the correct dose to our very young ones. It's simple and easy to maintain. As you can see, it's a very simple and compact gadget, and it costs a fraction of the previous Cpaps that have been available. So a lot of times you get the question is, where are you manufactured? The Vayue devices are US tech, manufactured in Kenya, Kilifi at Revital. And Revital is an amazing partner. And recently, for those of you who've been following the global updates, they were actually featured and had a trip to Atlanta with the president. They are our region's largest medical device manufacturer. So Vayue is currently in 28 plus countries. And as you can see in the map, we are in the Americas, we're in Africa, we're in Asia, we're also in Eastern Europe. Allow me to play you a clip that really shares more about Vayue and what we are about. Thank you.
Five million children die annually before their 5th birthday from preventable illnesses. Respiratory distress is a leading cause. With appropriate care, many of these babies can be saved. Bubble Cpap is a highly effective treatment for respiratory distress, and Vayue makes it accessible to babies around the world. The Vayue B Cpap system is the first low-cost, high-quality newborn and infant Cpap system that does not require electricity, compressed air, or advanced bioengineering support. The Vayue B Cpap system uses an external oxygen source, such as a wall source, oxygen cylinder, or high-pressure oxygen concentrator. From the source, oxygen tubing connects to the Vayue blender. The blender innovatively blends pure oxygen to an adjustable concentration with atmospheric air by the Venturi effect. This ensures the patient does not become hyperoxic and helps prevent consequences such as bronchopulmonary dysplasia and retinopathy of prematurity. The blended air is then filtered using a reusable filter, which removes viruses and other pathogens. The gases are then humidified in a bubble humidifier to prevent the patient's airways from drying out. Now that the gases are blended, filtered, and humidified, they are ready for the patient to breathe through a pair of silicone binasal prongs. The gases then flow into the pressure generator, which generates pressure to keep the baby's lungs open. This can provide from 4 to 10 centimeters of water pressure, depending on the depth of the wand. The device can be seen bubbling, which means that it's working and the patient is receiving respiratory support. Vayue Bubble Cpap has been used in more than 20 countries. Here are some experiences from healthcare professionals from around the world.
Our use of ventilators has actually decreased, and even our use of surfactant in managing these infants has also gone down. These are the babies who were, prior to the introduction of the Vayue Cpap, were either manually bagged, ventilated because of the availability of ventilators, until they died. So the Vayue Cpap has really helped us a lot in the care of these small premature infants.
What I can advise other healthcare providers regarding the use of valuable Cpap. This is something we in the lower middle income countries have been looking for. It's the device that does not require electricity, and therefore if you're in a facility that uses oxygen cylinder, the valuable Cpap can be connected and offer the optimum support that is expected.
Before we had Vayue Bubble Cpap, we had a complex electronical device, which was hard to use. Only a few nurses knew how to use it well, and it was always a bit of a struggle to start a baby on Cpap. With the new Vayue Bubble Cpap device, it's so much easier because we all understand what we're doing, and we can understand the device because it's so easy and well organized.
The Vayue B Cpap system has been implemented across 25 hospitals in Ukraine to help save the lives of premature babies, even in frontline hospitals where there is no electricity. The war has caused extra stress on pregnant women, leading to an increase in the number of premature births, which has tripled in some areas. In partnership with Unitaid, Vayue donated critical respiratory support devices that have been used to treat over 1,000 Ukrainian babies in respiratory distress.
Системи Vayue Cpap важливі для наших пацієнтів. Вони дозволяють продовжити дихальну підтримку навіть в умовах бомбосховища, в інших пристосованих умовах. Ми маємо пацієнтів, які одужали і виписалися завдяки застосуванню Vayue Cpap. Тепер ми можемо поділитися досвідом з іншими медиками. Це ефективний пристрій, простий в користуванні, може використовуватися в будь-яких умовах при наявності джерела кисню.
The Vayue Bubble Cpap is designed to work in any setting, improving the health outcomes of infants suffering from respiratory distress around the world.
Thank you very much for watching that clip. Allow me to just dial back a bit. As you've heard that the need that the Vayue Bubble Cpap addresses is affordability. Is it acceptable in our setting? Is it easy to, and is it feasible to implement in our facilities? That's correct. Safety and simplicity to use, that is also present. And what Dr. Okwonkwo has shared is an amazing summary that I honestly have very little to add to. Again, when we look at our African setting, we have a number of blackouts. Our power backup is a challenge. For instance, in Kenya, where we have public facilities, the best they can do on a regular day is 2 hours backup. And I know in Nigeria, power outage is also a big challenge. So the peace of mind one has as a healthcare provider taking care of the newborns with the Vayue Cpap is whether your blackout comes in or not, you know your babies will continue on care uninterrupted, reducing the risk of hypoxic injury to their brains. Excuse me for a bit. Yeah, so I'm trying, sorry, tech is failing me a bit. I want to get back to my slides. If Philip could assist me, please. Okay, thank you. So this shared, we currently have licensing for sale in Nigeria, Ghana, Kenya, Uganda, Tanzania, and it's ongoing in Rwanda and Ethiopia, and soon to come in other regions as demanded by our customers. Allow me to share some previous notes of thanks from the time it was used in Ukraine. During the setup of the war, there was a lot of bombing, and they had to create care centers for newborn babies. The stress of war caused a lot of prematurity, and the notes on the screen are from the caregivers. I'll just read one. Dear Thomas, 3 Cpap systems were successfully delivered to the perinatal center of